of the speakers that have been here before you guys are really impressive, world-renowned experts, and to be among those people, it's really an honor for me. So thanks again for having me, and thanks again to Pete. He was the one that alerted me to this forum, and I think it's an awesome resource. I'm really happy to be here, and I'm glad to see all of you here too. So just a little bit about me. I think we kind of went over it a little bit, but I'm from Portland, so I'm a West Coast person. It's great to have settled down here in Southern California. I work in Orange out of St. Joseph's Hospital, and I'm mostly there operating. Some of my interests, they are generally urology, so I take care of avoiding dysfunction stones. But by virtue of going to USC, I actually had the opportunity to do a lot of urologic oncology and a lot of minimally invasive surgery. So I definitely use the robot a lot to treat prostate cancer as well as kidney cancers. And another area that I actually had a lot of exposure to was prosthetics and implants and reconstructive surgery, because we had a gentleman up at USC named Stuart Boyd, really high volume implanter, really took care of a lot of these quality of life issues, and I had the opportunity to learn from him. And so, those are some of my interests and some of my expertise is, minimally invasive surgery as well as some of those quality of life surgeries, which we'll talk about a little bit today. So the main things, like we said earlier, that we're going to focus on are erectile dysfunction as well as urinary incontinence after surgery or even radiation too. So first let's start with erectile dysfunction, and we'll just kind of go into some basics and then we'll go into specific treatments. So what is it? It's the persistent inability to achieve or maintain an erection firm enough to have sexual intercourse. So that's sufficiently vague to encompass people that can't get an erection at all, or if you're able to get an initial erection but just unable to satisfactorily maintain it. And the thing to know about it is it's very prevalent. So 1 in 5 Americans over the age of 20 have experienced it in their lifetime. Furthermore, over half of men over the age of 40 have some degree of ED, so it's super common. 39 million American men are estimated to have some degree of erectile dysfunction. So, it's a really common thing, and people often have a hard time bringing it up to their doctors, but it's an important part of your life, and I think it's something that people should know is really common. So, first of all, we should go into the physiology of an erection. So the way an erection works, so when people are aroused, the nerves around the penis become stimulated. And basically what they do is they cause smooth muscle that surrounds the arteries in the penis to relax. What that does is it causes those arteries to expand and increase blood flow into the penis. It fills up these two little kind of cavities in the penis called corpora cavernosa. And when those corpora fill up with blood, the penis becomes engorged and it becomes erect. In the process, it actually compresses the veins in the penis. Veins are normally responsible to drain the blood. And so when you compress those veins, they don't drain quite as well. That's what maintains the erection. So more often than not, if there's an issue with the erection, more often than not, it's a blood flow issue. It can also be a neurogenic issue, which we'll talk about also. So common causes of erectile dysfunction in men. So the top 3 are vascular, diabetes, and medication related. So vascular, that's anything that has to do with impairing that blood flow that I was talking about. So that's atherosclerotic disease, that's high cholesterol, high blood pressure. All those things can affect the ability to achieve and maintain an erection. Furthermore, diabetes, which is super common. Diabetes actually affects both the small vessels in the penis, so the actual blood flow, and then it also affects the nerves. So it also affects the ability of those nerves to signal to those smooth muscles to relax. And furthermore, there's medication-related ED. A lot of the antihypertensives can cause deep impaired blood flow to the penis. And another category is antidepressants. Antidepressants are very commonly associated with erectile dysfunction. And then on top of that, there's obviously the reason why a lot of you guys are here is because of prostate cancer treatment. So prostate cancer itself doesn't necessarily cause erectile dysfunction, but oftentimes the treatment does, and those things are surgery or radiation, and we'll go over why in just a second. So, sexual dysfunction, like I said, after prostate cancer treatment, very, very common. So, if you looked at different studies, you would see they would quote different rates of erectile dysfunction among all men. It would be anywhere from 25 to 75%. But if you look at patients that are treated for prostate cancer, either for radiation or for surgery, it's almost half of those men have some degree of erectile dysfunction. And I'd even be willing to bet that this is a little underestimating that number. When I counsel patients for surgery, I tell them, your function afterwards, it's going to be very dependent on what your function was before. There's no way it's going to get better. Oftentimes it stays the same, but in a lot of cases, you're going to need a little bit of help afterwards. And there's several ways to help. So let's talk about some of those. So those include medications, injections, implants, VEDs, and urethral suppositories, which we can go over in a little bit more detail. So first off, the oral medications. So those are your Viagra, your Cialis, your Stendra, Levitra. They all kind of work the same way. Basically, they increase the blood flow to the penis. The way they do that is they actually inhibit a specific enzyme called phosphodiesterase 5. That enzyme is responsible for breaking down a specific neurotransmitter that keeps the veins, or that keeps the arteries open. So if you allow more of that vasodilator to be there, then you obviously can maintain your erection a little bit better. Things to know about these PDE5 inhibitors is that they definitely require stimulation. They're not going to automatically give you an erection. They usually have to be taken within an hour or so of anticipated sexual activity. So there is some timing associated with it. The one exception to this is Cialis. So Cialis actually has a really long half-life. So you can be a little bit more spontaneous with it. You can even take it in the morning, and it'll still be effective later on in the evening. Typically, we tell patients don't take this more than once a day. And I will say they're very effective. So depending on the patient, if you were to look at everybody, and this includes patients who have been treated for prostate cancer as well as those that haven't, about 60 to 80% of patients will have a good degree of efficacy. However, specifically in this group with prostate surgery or even radiation, the pills eventually stop working, and it's even less so in patients with diabetes. And that has a lot to do with the physiology of those erections and the physiology basically the physiologic changes that happen when you get something like surgery or radiation. Basically the nerves, well, I'll show you a photo later. We'll take a look at why that happens. The common things about oral medications, you can get some headache, you can get some facial flushing, stuffy nose, upset stomach. I would say of those things, the most common thing is the headache that patients complain about. You can actually just take a little bit of ibuprofen, sometimes that helps, and it makes it tolerable. Things to watch out for. So certainly you have to be healthy enough cardiovascularly to have sex in order to take these PDE5 inhibitors. And if you take other antihypertensives, they can cause your blood pressure to drop. So specifically, you'll hear on the commercials, if you take nitrates for chest pain, don't take Viagra, don't take Cialis. The reason why is because of the unsafe drop in blood pressure, and it could make you faint, and even worse than that. The next thing we can talk about is the vacuum erection device. It's actually probably the original treatment for erectile dysfunction. It's been around for a really long time. And the reason why is that it's pretty effective. So basically it's a thin hollow plastic tube that's placed over the penis, and then the pump actually creates a vacuum. So you evacuate the air from that tube, and that pulls blood into the penis. Once the blood's in the penis and it's erect, you usually use some sort of rubber band or some sort of elastic device placed around the base of the penis that helps maintain the erection. It's really effective, so it's completely mechanical. In about 60 to 80% of cases, actually, it's going to work. But despite that, a lot of people stop using it. And the reason why is because it can be uncomfortable. So first off, that rubber band that's sitting around the base of the penis, that can block ejaculation. It's going to compress the urethra and not allow the ejaculate to come out. Furthermore, you can get a little bit of bruising on the penis, and then you can get kind of some numbness, coldness. That has to do with the fact that you're basically occluding that blood supply with that ring. The other thing is lack of spontaneity. You know, this is a relatively sizable device. It's about this big, and let's say you're traveling, it's not exactly the most discreet thing. So a lot of people stop using it for that specific reason. The next thing is a urethral suppository. It's another name for it is Muse. That's one of the brand names. But basically, it's a medication that you insert into the urethra. It's not super effective. I will say, in my experience, about 50% of patients achieve some sort of erection with it. The most common complaints are burning with urination or pain in the urethra. I've never actually recommended this to someone, but it is something that some people have used and have told me that it's efficacious. So, you know, if it's something that people want to try, I'm okay prescribing it, but it certainly is not something that I would go to first. And the next is intracavernosal injection therapy. So this, I think, is actually really effective. It's an injection of a vasoactive medication directly into the corpora of the penis. And it works within 5 to 20 minutes, and it doesn't require stimulation. So you basically inject it and it starts to give you an erection. Of course, the erection is better if you are stimulated as well. So, you know, it's effective, like I said, but once again, people often stop using this. And the reason why is it's a little bit painful. You're sticking a needle into the penis, and although it's a very thin needle, it can cause a little bit of penile pain. The actual erection itself sometimes causes pain when you put this specific medication into the penis. You can get something called penile fibrosis or scar tissue. That primarily happens if you're injecting for prolonged periods of time into the same place. It kind of causes buildup of scar tissue and can cause something called Peyronie's disease. That's why whenever I give this to patients, I always counsel them they should vary the site of injection, so you should always inject in a different place and move it around. It can cause a little bit of bruising, it can cause a little bit of bleeding. So oftentimes, you know, patients don't really like this, they want something else. And that's something else, and I think that this is kind of, if everything else has failed, then this is really kind of like the gold standard. It's a penile implant. And so the way it works, it's very physiologic. So basically what happens is the area where those corpora cavernosa were, those are basically replaced by inflatable cylinders. So those cylinders are placed inside the penis, and then there's two other components. There's something called a reservoir, and there's something called a pump. And so the reservoir has fluid in it, and then the pump sits in the scrotum. And the way you activate this device is you basically pump the scrotum, the pump in the scrotum. That causes fluid from inside the reservoir to actually go into those cylinders that are sitting inside the penis, and it gives an erection. Once you're done, then you can actually activate a little valve that sits on that pump. It causes the fluid that was previously in those cylinders to go back into the reservoir, and the penis becomes flaccid. Like I said, very physiologic. That's the same way an actual physiologic erection works. And as a result, it's a really effective device. You know, if you were to survey people who have had it done, you know, really high satisfaction rates, 96, 97, 98%. And even though this is a mechanical device, and even though it has you know, several parts to it, especially this particular device doesn't need that many revisions. So studies have shown that, you know, at 7 years, over 90% of these patients don't need any sort of additional surgery. There are obviously, you know, this is a surgery to implant this device. There are obviously potential complications involved that I always counsel patients about before we do this. And the main things are, you know, this is a mechanical device. There's a chance that something fails, so maybe a little tube leaks, or maybe the pump doesn't work quite the way it should. It's always revisable, but that does require another surgery. So that's definitely something to know. That rate, like I said, is really, really low. You know, it's 1-2%. There's a chance for infection, and it's When you get an infection on one of these devices, it's a little bit different than if you were to get a standard post-op infection. Usually that you can treat with some antibiotics. In this case, you usually have to remove the device because you're not going to be able to get those bacteria off the device. Oh, this works. So this is a nice little animation, but basically you can see you're pumping up the pump. It's causing that fluid to come out and enter the cylinders, and that gives you a good physiologic erection. And then when you're done, you push that little button that's on the pump, causes the fluid to come out and go back into the reservoir, and it's flaccid. So like I said, really, really, something that's very helpful to patients' lives. It really gives them back this aspect of their life, especially if they've tried these other treatments and they're not effective. Even partners report a lot of satisfaction. 96% of partners reported satisfaction. There's a slide in here about insurance coverage. A lot of times this will be covered by Medicare, it will be covered by private payers, and so, I don't think that's usually an issue. If it is, you can talk to Pete, he'll help you. And then, like we talked about, some of those possible surgical risks, like I said, they're pretty limited. I think the infection rate among these devices, if you were to look at big studies, are anywhere from 1% to 2%. Same with revision rates. So quite safe and very effective. So with that, let's move on to stress urinary incontinence. This is also a very common thing that occurs after prostate surgery. So what is it? It's bladder leakage. It's basically when your urinary sphincter, which is the muscle that's responsible for controlling your urine, is unable to keep your urine in. So anytime you increase your abdominal pressure, so that's when you do stuff like laugh, or walk, or sneeze, basically any sort of pressure on your pelvis is going to make you pee, and you're going to be unable to control it. After prostate cancer surgery, it's super common, and we'll go over why in just a second. But 50% of men, I would say probably more, I tell every patient that you're going to leak at least a little bit right after I take out your catheter after prostate surgery. They will have some leakage, and most of them actually get better within the first, I would say, 3 to 4 weeks, and certainly within the first few months. But there is that subset of patients that will have persistent stress urinary incontinence even after 1 year. And that's not a small number of patients. It's estimated at approximately 500,000 patients, 500,000 men in the United States suffer from stress urinary incontinence after prostate surgery. So here's kind of the physiology of urination. There's a couple different organs and a couple different areas that are affected when you do prostate cancer surgery. So here's your bladder. It's responsible for storing the urine. The urine then travels through the urethra and then out the penis. The things that help you control your urine are muscles that basically surround this urethra, and then something called the sphincter, the external urethral sphincter, which sits down below the prostate. So in order to maintain continence, this sphincter muscle has to basically squeeze around the urethra and basically keep it closed. When you do a surgery, you're basically disrupting a lot of the support that goes around this urethra, and a lot of support that's actually around this sphincter muscle. And that's the reason why you get incontinence. So, like I said, about almost 15-16% of patients after surgery will end up developing this incontinence. Other causes are potentially neurologic, so if you don't have good nerve innervation to those sphincter muscles, you can also get a little bit of leakage. In radiation and in BPH surgery, you can also get some of the incontinence. It's pretty rare though, less than 3%. And then also in pelvic trauma, you can get some incontinence. But as we were talking about before, this prostate is very intimately associated with the bladder as well as the muscle and the sphincter and the urethra. And when you cut this out, you basically have to remove the prostate, and then you sew these two areas back together. When that happens, you actually have a disruption of all the muscles that support the urethra and that support the bladder. And because you don't have that support, that external sphincter on its own is not usually able to control the urine until some of those muscles regain the strength. Another thing here that I should mention is that these nerves right here, it's called the Neurovascular Bundle, also very intimately associated with the prostate. These are the nerves that actually are giving the penis innervation for erections. And so when you end up disrupting these, sometimes we try to spare them with prostate surgery, but oftentimes they do get disrupted, and that's what's responsible for the erectile dysfunction that you get after prostate cancer surgery, and even after radiation, because those are affected. Yeah, we kind of went over some of this already. So, what are ways to sort of return people to normal, kind of give their quality of life back and treat this male incontinence? Well, let's go over some of them. Oops. So the first thing is behavioral modification. So people do this naturally. So they realize they're urinating all the time or they're leaking urine. They stop drinking as much water. They start planning their bathroom breaks every hour. I need to go to the bathroom. I need to plan out when I go somewhere. Does this place have a bathroom? You can do that for a short amount of time, but that really disrupts the quality of your life. You're not really able to do the things that you were doing before surgery. Next up is intervention. So things like pelvic floor physical therapy, Kegel exercise, biofeedback. All of these are actually centered on re-strengthening those muscles. So those muscles that we've interrupted and those muscles that we've disrupted when we do surgery, those exercises work. Anytime I do prostate cancer surgery, anytime I do a prostatectomy, I will always make my patients do this. It helps regain continence right after surgery. And then, if that's not successful, then a lot of times patients, have to resort to these other coping mechanisms. So they can't stop their leakage, so they come up with ways to cope with it. So those are things like pads, diapers, condom catheters, penile clamps. All those sort of things are kind of short-term fixes. A lot of people kind of spend a lot of their life using some of these coping mechanisms because they just don't know that there's other options out there, which is why it's kind of important to talk to your doctor and learn about some of these things. So, looking at pads and diapers, they're not a small expense. So, if you were to look at the 5-year cost of diapers, it's actually pretty high at $7,000. Other things to know about them, they can definitely leak, they can smell, they can be indiscreet, and they can really kind of disrupt the quality of your life. They're not physiologic by any means. So there's really a couple ways to help control urinary incontinence that go beyond coping mechanisms, that go beyond exercises. And 2 ways are something called a male sling, and the other one is an artificial urinary sphincter. And we'll talk about each of these in a little bit more detail. But a male sling, it's basically meant to help regain some of that support that you lost from those muscles. It's a little piece of soft mesh that sits inside near the area that we cut. And it helps provide it's like a little hammock. It sits underneath the urethra. I'll show you a picture in just a second. But it's appropriate for mild stress urinary incontinence. So if you are going through like 5-6 pads a day, it's probably not going to work. But for mild stress urinary incontinence, it's actually very effective. The other thing is an artificial urinary sphincter. This is supposed to basically mimic your natural sphincter, and it can treat any degree of stress urinary incontinence. And there's a couple different components to it, which we'll go over. So this is the sling. Basically, in this area where the prostate used to be, you place this little mesh hammock, and it actually reapproximates some of these muscles and helps kind of provide a little resistance that can help patients regain their continence. Like I said, it's good in patients that are less than 4 pads per day. And there's a high satisfaction rate, but with the caveat that, your doctor has to really select carefully. If you have, more significant leakage, just this little hammock here is not going to do the trick. The nice thing about a sling is that it's really simple. It's minimally invasive. We just make a small incision kind of underneath the scrotum. We're able to put it in. You can go home the same day, and it works immediately. So you'll notice right away that you're continent. And like I said, it helps restore normalcy. It helps restore your quality of life. The other thing that we talked about is the artificial sphincter. So the artificial sphincter has 3 components, kind of like the inflatable penile prosthesis. It's got a cuff, which is like a little donut. It's an inflatable donut that goes around the urethra. It's got a pump, which helps activate the cuff, and then it's got a little reservoir, which contains fluid. The way it works is at rest, this cuff is inflated. So it's squeezing the urethra and it's squeezing it shut. That helps prevent urine from leaking out. When you have the urgency to urinate, you basically press on this control pump and it causes fluid from inside this cuff to exit the cuff and go into this reservoir. And what that does is that it opens up the donut and it allows the urethra to open, and then you void the same way you would have, before you had surgery. It's very physiologic. After a couple minutes, the cuff actually automatically refills, and then it squeezes the urethra shut again, and once again, it maintains your continence. Here's a little animation of how it works. So it opens up, and then automatically fills back up after a minute or so to reinitiate that continence. So once again, really, really, really successful surgery and a lot of satisfaction associated with this system. There's a number of different manufacturers that make these. I've always used these Boston Scientific or AMS devices. I think they work really well. So, like some of the things we went over already, it really mimics the physiologic sphincter, really high success rate, and it's entirely inside the body. You don't have to carry around a bag, you don't have to carry around diapers, it just works. So a couple things that we always talk about is some of the potential complications or some of the potential issues that could arise. Once again, it's a mechanical device, so you could always have a failure in one of the components, which may require revision. I will say that in my experience, there's a little bit more revision associated with the sphincter. You may need to kind of tweak a couple things, either the pressure of the system or the size of the cuff, to make sure that you've got optimal continence. But these are usually pretty minor surgeries. We'll also say that you're not going to get immediate continence after you get this artificial sphincter. And the reason why is you actually have to let the area heal before you activate the sphincter and let it start working. But like I said, really, really works well. Insurance coverage, once again, it's covered by most Medicare and private payers. Okay. Well, so that basically covers, some of the treatments and some of the potential some of the potential things that you can do for erectile dysfunction as well as urinary incontinence. And I will tell you that these are really, you've gone through prostate cancer, you've survived that, but just because you've survived it doesn't mean that you're back to your normal life. These devices really help you do that. And I will say that, it does require some special training to be able to do these surgeries, and not every urologist does. So, certainly this is something that should be offered to men that have this particular issue. And, if for some reason your urologist doesn't, you should certainly try to seek one that does, because, like I said, it's for you, it's for your life. So thank you very much once again. I really appreciate you guys coming out to see me, and I really appreciate being here. And I'm happy to answer any questions. Thank you.
Thank you so much, Doctor, for an excellent presentation. There's a couple things that I'd like to mention to you. One is that we have a lot of pizza left over, so on your way out, please go to the area where you can take some home. The second thing is Carolyn Amundsen is... Carolyn, would you stand up, please? She is one of the individuals that is bringing a number of ladies together as a sister organization to the prostate cancer organization, and they meet every 2 or 3 months. Carolyn, and a big help to our group, and we're certainly indebted to all the help she's given us, her and her associates. Carolyn, would you like to say a few words, please?
I have a little black book, and in my little black book, I'm putting down the names of any ladies with your emails and your addresses and phone numbers, so that I might add you to. Thank you, Larry. Add you to my email list, so that when we have a periodic lunch gathering, I can get in touch with you and we can meet and enjoy communing about everything related to prostate cancer. And so I hope to catch all of you before the evening's over, and look forward to getting better acquainted as time goes on. Thank you, Larry. We're going to meet once before school starts.
I know a couple of ladies that went to these meetings, including my wife, and they all have they're all very appreciative of our efforts in terms of bringing these people together and in the support they give our group. So if you're interested, please see Carolyn. The other thing is my wife brought home a good pie from Marie Callender's, okay, as a result of the meeting. Okay, so now we're going to, people that have questions, please raise your hands and I'll bring the microphone to you. Any questions?
Yeah. My question regards testosterone levels. Had Luprin regarding my radiation treatment. Luprin has been ceased over a year, but my testosterone is not going up. My sexual function is definitely staying down. So testosterone.
What was the, sorry.
The testosterone.
Oh, so the question was, what's going on with the testosterone?
Well, what is the long-term side effects of the Luprin, which lowers the testosterone level? My testosterone has not gone up, but is that what is truly causing my erectile dysfunction, or will that get better over time?
Good question. It's a little bit difficult to say exactly. I would think that a lot of the reason why erectile function has suffered was due to the treatment, so radiation. So even that can damage the nerves that are running alongside the prostate. So even if the testosterone level were to restore back to normal levels, I would probably bet that there would be some degree of erectile dysfunction there. So some sort of additional treatment would probably be necessary to help restore that.
Wonderful, thank you.
I'd like him to clarify, did you have a surgery?
Yes, I had a full radical. A year and a half later, it did come back. I went through 37 treatments of radiation. I was given the Lupron to drop my testosterone down to 9. It has not come fully back up yet. This was over a year and a half ago.
Yeah, the reason I asked that is because I was diagnosed when I was in the beginning, and the doctor never sat down with me and gave me a plan of action. And the first thing he did was give me a Lupron. And the next doctor that saw me, he said, "Why are you giving me Lupron?"
Yeah.
Okay.
No, that's a little unusual. Typically, anytime you do these treatments, and I always tell patients this, if you get surgery, the chances of you having exactly the same function afterwards are lower. I mean, some patients recover really well. It's totally dependent on what your function was before. But like I said, I wouldn't be surprised if even when your testosterone levels recover, if things aren't quite as good as you want them to be.
So has your testosterone level recovered, or is it still low?
No, it has not fully recovered at all. It's still staying
What is the possibility of testosterone supplementation in that kind of situation?
Well, that's a good question. I would, well, considering or assuming that your PSA level is negative and gone down to 0, then I think it is possible. I would give it like a year though. I would make sure that your PSA was completely negative. I would wait before considering any sort of testosterone supplementation. It's usually not advisable right after you've had, especially recurrence, and further treatment.
So PSA or testosterone supplementation is controversial.
It was over a year and a half ago. And so I have been thinking about taking the supplements. And as I've been told, prostate cancer loves
No, I mean, some people will. I personally don't. But I know that there are people out there that will do testosterone supplementation after a certain period of time of negative PSAs.
Wonderful, thank you.
Thank you. Any other questions?
So just for medication purposes,
Yeah.
how long do you typically wait?
How long do you typically wait before like a medication like starts to wear off out of your system? Are we talking 6 months? Is it 3 months for like an oral medication? Say like an Xtandi, you take a Lupron. How long does it take for those to work?
They're all different, right? So they all have different half-lives. So Lupron, we typically say it's going to be, well, it depends on what dose you were given. But yeah, it can take months. So depending on the dose, it can take anywhere from 3 to 6 months to basically wear off in your system. Xtandi, I believe, is much shorter. But yeah, it's totally dependent on the medication and its half-life.
Like a Firmagon?
Firmagon, I'm not exactly sure what that is off the top of my head, yeah.
Any other questions?
Yeah, I got one. I'm kind of curious in the presentation.
Yeah.
You never discuss anything about climatic effects with all these supplements that you're putting in, the implants and so forth.
What about them?
Well, I mean, so do you reach it quicker, faster, sooner? Does it have the same?
It
No,
should be,
excitement
so
or-
it should be very comparable to, like I said, it's very physiologic. So, even though you're not able to get physiologic erection, your physiologic arousal is going to be very similar. So I would doubt that you would, you're not going to be lasting forever. You might be able to maintain an erection forever, given the fact that you have this device. But as far as how long it takes you to reach a climax, it should be pretty similar to how it was before when you were getting a normal erection.
And then when like the Viagra, they say if you have an erection more than 4 hours, get a hold of your doctor. So what's the deal on that?
Well, with the implants, you could theoretically have an erection forever, but it's not dangerous. All you have to do is you have to push the button and let it deflate. I've certainly had an ER call when I was a resident for someone with one of these devices saying, "This guy has an erection, it's just not going down." And I go down there and he has a prosthesis.
You got an appointment for tomorrow?
I'm gonna actually leave my cards in the back. You can get it. Back in the, or we can just pass them out. But yeah, I'm happy to see anyone. You just have to call my office, make an appointment. We can get you in pretty soon.
How do the side effects of surgery compare with radiation?
Oh man, that's a loaded question. Well, I will say that therapies have changed a lot. So I would say in the last 10, 15 years with the robot, I would say that nerve sparing is a little bit better and it's a little bit easier. I would say before the robot, actually sparing those nerves that provide innervation to the penis and to give you erections was a lot more difficult, and it was really only the very good high volume surgeons that could really effectively do that. Now we have much closer visualization with this robot. I think it's a little bit easier to spare those nerves. But with that being said, I think that you're definitely going to see a lot more short-term side effects with surgery. So you're going to have that incontinence and ED. You're not going to have that immediately when you get radiation. It's gonna start to affect you anywhere from 6 months to 10 years down the road. You might start to see some of those irritative voiding symptoms with radiation, erectile dysfunction with radiation. In surgery, those, like I said, those effects tend to get better over time. With radiation, those effects tend to get worse over time.
Which one has more side effects? Specifically, not worse and better, but which has less side effects, surgery or radiation?
Well, they both have their own side effect profile, so it's not like one has a lot more than the other. It's just a matter of how they affect you and when they affect you. Immediately right afterwards, surgery has a few more side effects.
Let me add something to that.
A lot of that is dependent upon the doctor and the equipment that's available to you. A doctor that has done thousands of radiation therapies, is going to have a much higher rate of success than someone that has a lower experience level. Also, the type of equipment, you have 1.5 versions of radiation therapy equipment. You have 3.0 versions, The 1.5 version is a much older piece of equipment, 3.0 is it's much newer and more precise, so, that has
and
great...
there's new things that we're doing now. For radiation. We do something called space ore, which is basically like a little hydrogel that sits between the rectum and the prostate, and that prevents some of the toxicity when it comes to radiation. So a lot of urologists are providing that service. So, things are changing, but I would say they're both efficacious. I would say that the treatment success of surgery and radiation are pretty comparable. It just has to do with, the choice is ultimately going to be dependent on, whether you want, some of these, whether you want to kind of have more side effects immediately that'll get better, or if you're going to have more side effects down the line. But operator dependent, like we said.
But the space ores is not going to have any effect on the nerve bundles that you're talking about?
It shouldn't, no. It's more for like rectal toxicity. A lot of times the rectum gets a lot of radiation. You can get, it's called radiation proctitis, so the space ore helps with that.
So when you have robotic radiation, is that better than manually controlled by the doctor?
Radiation?
Yes.
I don't actually do radiation, so I couldn't tell you for sure. You'd have to talk to a radiation oncologist about that. But as I understand, they basically create a little map of the prostate, and it's targeted. It depends on the tolerances that the doctor sets for the prostate. So yeah, I think, like you said earlier, like you alluded to, it's operator dependent.
Yeah, you want to find somebody that's done thousands of them.
No, the reason I asked that because I have read about radiation done manually and radiation that's done robotically. So if that robotic is controlled by computer, so there's no manual input at all in that. So is that better than?
Yeah, so I think it's totally, you would have to ask a radiation oncologist about that. But, from what I know, I think it totally depends on who's created that map, the tolerances that they've set. I think either one could be effective.
Well, the reason I asked is because my urologist recommended that I consult radiation specialist, and he sent me to 2 radiation specialists. And the one in the hospital, he didn't even examine me, didn't even explain to me. I had to cancel at the last minute. I said, no, I don't want to do it.
Yeah. Yeah, no, I think that's probably the most important thing is you have to go with someone you're comfortable with. And, you should always be counseled. Your urologist will be able to tell you a little bit about radiation.
But ultimately, the person who knows the most about it is the radiation oncologist. If they're not willing to take the time to counsel you on this, then it's probably not worth going to them. You probably should go to someone else.
Thank you.
At the prostate forum, we always recommend that you see 2 or 3 doctors before you make a decision. And you go in with a list of questions and you see how they answer them. Okay, are you comfortable with their answers? The other thing is you ask them what their cure rate is, what their side effects are, what their experience is. And some of the better doctors, they keep track of their side effects. Okay, from patient to patient. Statistically, they keep track of it. Those are the kind of doctors that you want to give attention to, because when they keep track of their statistics, they're doing it for a number of reasons, but one of the reasons is they're trying to improve their process. And if you don't keep track of your statistics, how can you improve your process? You don't have any baseline. So, talk to 2 or 3. And here at the Prostate Forum, we have names that we can, give you.
Well, I go to CRI conferences.
Good.
And also, I'm forgetting the name of the doctor that runs it, and he was recommending on his seminar
Yeah.
that, not to have radiation, not to have biopsy, but have it MRT. Is that MRT? Am I right? Is it MRT?
The IMRT is the
IMRT is
therapy.
radiation, yeah.
Yeah, but MRT, a picture of your prostate instead of getting a biopsy.
Well, you can't really diagnose prostate cancer without a real biopsy. Obviously, if you get an MRI of the prostate, it can help detect high-grade lesions that might be suspicious for prostate cancer. But the only way to truly diagnose it is to target those lesions and do a biopsy.
So MRI, there are places that you can go to, okay, that uses MRI in combination with ultrasound, okay, to locate and identify cancer within the prostate gland. And then once they locate the prostate cancer in the gland by using these diagnostic tools, then they map it out and they go in and then they perform a therapy, and then there's a number of different therapies that they can utilize, okay, in addressing the cancer. So one of those places is Desert Springs, okay, and the doctors have appeared here previously, and they're one of the pioneers that have used MRI, okay, with ultrasound to locate the cancer and to, after it's diagnosed, then to use those technologies to beam on the cancer with a number of different therapy options. Any other questions?
Slightly off topic, but I'm interested to know how prevalent is MRI-guided robotic surgery is to improve surgical margins.
MRI-guided MRI-guided robotic surgery?
Yes.
Well, I typically get MRIs on the majority of my patients with prostate cancer because I'm looking for extracapsular extension of that disease. If there's extracapsular extension of the disease and that's clearly demonstrable, then you'll probably need radiation on top of getting surgery anyways. So in that patient, I might say you might as well just get radiation.
That's not my question. Like when you do a surgery, there's a surgical margin that you have.
Correct.
Right? And in order to improve the surgical margin, some institutions have used MRI to guide what they're doing.
Mm-hmm.
So I was just wondering how prevalent that is, and do you do that at St. Joseph?
Like I said, we always get MRIs. We always get an idea of what our extension of disease is going to be. As far as actually being able to map that out, I'm pretty sure that's that's really kind of a thing under study. I would say there's probably not a great correlation between the MRI and, at least in my experience, between the MRI and the actual final pathology. Certainly, the thing I was mentioning before, extracapsular extension. Certainly, I've gotten MRIs on patients that it looks like the disease is contained to the prostate, and then once we actually excise the specimen, you do have a extracapsular extension. So I don't think there's a great correlation so far. I'm sure there's a lot of research going on in that area. It's not something that we do at St. Joseph's. It's probably something that's probably confined to some
I think
academic
they do it at
institutions.
UCLA.
Yeah, it's probably mostly at academic institutions at this point in time.
Okay, any other questions? Thank you, and you have a good evening. Thank you, Doctor.
Thank you, sir.
Okay, that's the record of-
Thank you.